Hello everyone, welcome again to yet another lecture video from Orthoflex Mysore. My name is Dr.Inam Rahman Khan, and this video is mainly for medical and allied health students and also for clinicians because the topic that you are going to hear today is such that it requires intense understanding of it for anyone who chooses to be a good clinician irrespective of his or her medical field practice. Yes, you got it right. If you may have guessed, I'm referring about pain. Now, before starting off on the topic right away, let me put forward the objectives of this lecture and what is the outcome that I would expect after this. My objectives are that to define pain and understand the newer concept of pain along with traditional medical model of pain. At the end of this lecture, I would expect that you will be able to sketch the pain pathway, distinguish between types of pain and factors influencing pain, and you know where to look when the patient complains of pain and also to evaluate pain. Now, let me start by giving you the medical definition, or rather definition of acute pain, that states pain is a physical or emotional response to noxious stimuli. But this definition will not suffice to cover the whole paradigm of pain, because according to the definition I just stated, what one can infer is that if we remove the noxious stimuli, then the pain also will subside. But it is not the case always, because it does not hold good for chronic pain. So pain is much more to be defined than that. So in 1994, the International Association for Study of Pain came up with a definition that stated pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage. Now, if you think about it, now this statement also did not suffice. So the same IASP slightly changed the definition in 2016 that stated pain is distressing experience associated with actual or potential tissue damage with sensory, emotional, cognitive and social components. Further elaborating on the definition, the IASP says that the inability to communicate verbally does not negate the possibility that an individual is experiencing pain and is in need of appropriate pain relieving treatment. So pain is always subjective. Each individual learns the application of the word pain through experience related to injury in early life. Now, when we talk about pain, who do you think the first person was to feel and experience pain? Now, obviously, according to the mythology, it is Adam, isn't it? Now, what obvious pain might he have had suffered? Undoubtedly the pain of loneliness, isn't it? Now, God responded to Adam's cries for help and relieved his pain by sending Eve to earth. Now, we as clinicians also have the responsibility of putting an end to the pain and suffering of our patients, and one has to understand that it is not only our duty, but it is the right of every individual to be relieved of pain. So pain relief is a human right of every individual and not a luxury which only the privileged can enjoy. Putting more stress to it, I would like to say that medically the importance of pain relief is such that it is now considered as the fifth vital sign that has been recorded along with heart rate, pulse rate, respiratory rate and blood pressure. It is mandatory for a clinician to believe the patient if the patient complains of pain and just not assume that the pain is just in the psyche of the patient. Because many people report pain in the absence of tissue damage or any likely pathophysiological cause. Usually this happens for psychological reasons. There is usually no way to distinguish their experience from that due to tissue damage. If we take the subjective report, if they regard their experience as pain and if they report it in the same way as pain caused by tissue damage, it should be accepted as pain. Okay, now having said that, let me move to tell you where does the pain come from. Pain is often multifactorial. That is, the pain perceived by a patient may arise from a number of different structures, either locally at the site of injury or from some other point that may refer pain to the region perceived. Irrespective of the abnormalities that contribute to pain, direct pain assessment and treatment is mandatory. That is, if it takes some time for the clinician to pinpoint the cause of the pain, the clinician should address and treat the pain even without knowing the cause, which is called as symptomatic treatment. But the clinician has to make an effort to evaluate the cause of the pain as early as possible and subsequently treat it appropriately. Now, pain may be perceived via any of the pain sensitive nerve endings that are distributed extensively throughout our body. These nerve endings, known as the nociceptive nerve endings, are found within bones, cartilages, ligaments, bursa and neural structures, and also viscera. Now, stimulation of these nociceptive nerve endings will result in individuals perceiving pain. The stimulation can be mechanical or due to chemical reaction that takes place in response to cell damage. Whenever there is a cell damage or structural damage due to direct acute injury or due to wear and tear, there is release of certain chemicals from the damaged area, such as the potassium ions, the histamine, the 5-hydroxytryptophan, plasma kinase and prostaglandins. Now, these chemicals act on the nociceptive nerve endings that in turn lead to the release of a chemical known as substance P that causes vasodilation and subsequent inflammation. Now, again, this inflammation falls into the same cycle that started the cell damage, and again the inflammation will cause the release of all the chemicals such as prostaglandins that lead to perception of pain. Now, how are these prostaglandins or the mediators of pain synthesized? There are A delta fibers and C fibers, which are the free nerve endings on the skin and on the viscera. These sense the pain and temperature stimuli and then act on the membrane phospholipid, which in turn release arachidonic acid in the presence of phospholipase A2 enzyme. Now, it's good for you to know at this point that the synthesis of prostaglandin occurs from arachidonic acid with the help of an enzyme called as cyclooxygenase 2, or more commonly referred as COX-2 enzyme. Most of the non-steroidal anti-inflammatory drugs, that is your NSAIDs, work by inhibiting the COX-2 enzyme that as a consequence will stop the synthesis of prostaglandin and in turn will stop the inflammation and subsequently will reduce pain. Now, when you actually feel the pain, it means that a signal which may be mechanical, chemical or thermal has passed through your nerves to the sensory cortex of your brain, and that's why you are feeling the pain. Now, this pathway through which the stimulus passes to the brain is called as the pain pathway. Now, since the stimulus can be of any kind, of any energy, it may be mechanical, chemical or thermal. Now, it has to be converted to electrical potential for it to be passable through the nerves before it reaches the brain.